I would like to focus on the strategies that are available for us to improve transplant outcome. We're aware from a number of studies, but most importantly, I think the pivotal HOVON study led by Jan Cornelissen, showing that the relapse was 0.35 for patients who had a transplant compared with intensive chemotherapy. In other words, transplant is a highly effective anti-leukemic tool, and with the advent of reduced intensity regimens and improved strategies for donor choice, we're now able to deliver it with acceptable morbidity and mortality. And yet we know that although the risk of transplant to patients has fallen steadily over the last couple of decades, the likelihood of relapse hasn't changed. And this remains the dominant cause of treatment failure in this most effective of therapeutic modalities in acute myeloid leukemia. So if we're to logically think about how we might reduce the risk of disease relapse in patients having an allogeneic transplant for AML, a number of opportunities present themselves. Building on the important work that's just been referred to by Adriano, you could argue that reducing the pre-transplant MRD burden would be important. There's no randomized data to support that. Alternatively, we do know that the intensity of the conditioning regimen is important in reducing the risk of relapse, but the benefit can be offset by increased transplant-related mortality. But it's plausible that there are conditioning regimens out there, possibly using novel agents that have enhanced anti-leukemic activity with modest toxicity. And then finally, as Adriano has said, and I'll touch on this in some detail, there's a real opportunity to think about employing drug or cellular therapies as maintenance strategies. So if we're to think about how we deploy transplant most effectively, I just want to add to Adriano's really important observations, which is to say that NGS-based quantitation of MRD has been shown by Chris Hurigan to be an important predictor of risk relapse. But actually, there are no prospective analyses of flow, the impact of flow-determined MRD pre-transplant on outcome. And these data that I'm showing now come from the recently completed Figaro trial delivered by the NCRI group. This was a randomized trial of older patients, 244, who were randomized to receive either the Flam's-Abu sequential therapy or a conventional RIC regimen, Flu-Bu-2. I can tell you that there was no benefit associated with the use of the Flam's-Abu regimen. But importantly, and led by Sylvie Freeman, in this study, we were able to do, to our knowledge, the first prospective evaluation of the impact of flow-determined pre-transplant MRD. And Sylvie was able to demonstrate that using a cutoff of 0.2%, the presence of flow-determined MRD does indeed impact overall survival and relapse risk. But actually that the impact is perhaps less marked than has been reported in a number of retrospective studies. And importantly also that a significant number of patients who go into transplant with evidence of MRD by flow still have satisfactory outcomes and don't relapse, complementing what Adriano has reminded us about, that these patients should be considered for transplant. And then Sylvie was also able to apply an unsupervised methodology to remove any observer bias and confirmed again the importance of MRD pre-transplant and its impact on disease relapse. So if we think about why are we concerned about post-transplant MRD, the reason is simple. It is that there is a very powerful graft versus leukemia effect in patients allografted for AML. I remember at the advent of RIC regimens in the start of this century that many people thought there wasn't going to be a significant benefit of RIC regimens and that the GVL effect in AML was modest. Well, this data that we published from the NCRI group about 5 years ago complements Bacigalupo's seminal studies demonstrating that in patients with high post-transplant cyclosporine exposure, there's a much higher rate of relapse, something like a 40% higher rate of relapse. And therefore, there must be a very potent and indeed manipulable graft versus tumor effect after an allograft. And in this study, we confirm that that significant GVL effect can be exerted even after a T-depleted RIC using Campath. So what are the significance of that? Well, the other observation we made from the Figaro trial was an assessment prospectively of whether acquisition of full donor T-cell chimerism at day 100 impacted on patient outcome. And we particularly wanted to look at that according to patients' pre-transplant MRD status. And what you can see in this study is the overall survival of patients who were MRD positive, that's the black line that comes down very precipitately, who did not achieve full donor T-cell chimerism at day 100, very high rate of relapse, poor outcome, compared with patients, the green line, who were MRD positive, but did switch to full donor T-cell chimerism, whose outcome was exactly the same as patients who went into transplant MRD negative. In other words, acquisition of full donor T-cell chimerism can trump the adverse impact of pre-transplant MRD positivity. And this is being confirmed, also demonstrated in a study from a Chinese group demonstrating actually that intervention with DLI can improve outcomes in patients who are MRD positive. So what is the impact of detection of post-transplant MRD? And this is a nice study performed by the group led by Kim using NGS strategy, in which they were able to demonstrate, even on day 21, that the presence of NGS-determined MRD was associated with increased risk of relapse and poorer transplant survival. And I think it's important to note the red bars here, that the kinetics of relapse in such patients varied, but that the relapse was often quite rapid. And this is a very important point if we're thinking about evaluation and development of novel post-transplant strategies, is that we know from EBMT studies that 80% of patients destined to relapse after an allograft for AML will do so in the first year. And what this study is showing us is that in patients who are MRD early on, they will relapse quite quickly. And so interventions have to be applied early. And this is a similar work which confirmed the importance of pre-transplant NPM1 positivity on increasing the risk, post-transplant, both pre-transplant and post-transplant NPM1 transcript detection on relapse risk. What are the interventions? Well, I want to echo what Christian said about the very important study he and Uwe Platzbecker led, RELASER-2, a study in which in patients who had evidence of MRD, intervention with azacitidine after either application of chemotherapy or a transplant was shown to improve survival. And we also know that such patients are salvageable with a donor lymphocyte infusion. So in the last few slides, I want to just talk a little bit more about this growing area of maintenance therapy and its potential role in improving transplant outcome. So I want to think conceptually about if we apply pharmacological or cellular maintenance, how might that improve outcomes? Well, firstly, if we have an agent that can target the leukemic stem progenitor population, then we can augment the anti-leukemic effect of a transplant. But secondly, as I'll show you, I think there's a very important argument to be made that simply by delaying disease relapse, buying time for a graft versus leukemia effect may be enough to improve survival. And finally, there's evidence, importantly, not only with azacitidine, but also interestingly with FLT3 inhibitors, that you can modulate the alloreactive response. With azacitidine, it's through upregulating Tregs, Treg reconstitution and increasing expression of tumor antigens. And with FLT3 inhibitors, it's potentially by augmenting lymphocyte reconstitution. So what do I mean by buying time for the graft versus leukemia effect? Well, if we think that it's going to take a finite time to develop a graft versus leukemia effect because of growth of the transplanted donor T cells, it's possible relapse occurs before that. And therefore, anything that postpones relapse, allowing the GVL effect to kick in before the disease relapses, or anything that accelerates GVL reconstitution will be a benefit. So if we think then about how one might deploy such a beneficial strategy, moving on to my next slide, it's just been published in JCO, important data showing that sorafenib maintenance improves survival in patients transplanted for FLT3 positive disease. And there's a very important pivotal study just being delivered by the US CTN looking at the benefit of gilteritinib maintenance in patients transplanted for FLT3 positive disease. So it's going to be important to wait for those data. And then finally, through the UK NCRI and the Impact Transplant Network, we are delivering a randomized trial looking at maintenance for a year post-transplant using CC486 oral azacitidine, an important new agent in the management of chemotherapy alone, using that as maintenance therapy post-transplant. That study's already randomized 60 patients, and we hope will close out in about 18 months. So this is an important and exciting time for improving transplant outcome with an increasing focus on measuring MRD post-transplant and intervening through maintenance strategies. Thank you for your attention.